So how do you feel when things comes to the end?
So it's very interesting, right? As I said, a lot of my patients are quite elderly. And reflecting on what I do and the patients I see, you cannot have two groups of patients. Right? One is the elderly, the other group is the younger group, maybe with cancers, let's say, right? Because cancer can hit at any age, 50s, 60s, whatever. So with the very elderly folks, and nowadays elderly means 90 and above.
Yes.
Right? In the past, life expectancy wasn't so high. So patients die about 70 plus, 80 plus, but now we see patients 90 plus, 100, that's not uncommon anymore. So with the elderly patients, they have an expectation already, they kind of know, right? And their mindset is such that, okay, I'm comfortable with whatever it is, right? So dying isn't so traumatic for these patients. But I think really it's much more difficult when we are treating and interacting with the younger group, 50s, 60s, 40s even, right? So I think even for myself, right, I find it harder to work with these patients as well. Because I think when you're young, there's so many things you haven't done or need to do. And when faced with the prospect that life is ending, then that's actually a very difficult thing.
Your patient usually, how long are their life expectancy when they come to meet you?
Once again, two groups, right? So in the palliative circle, we talk about trajectories, right? You know, patients, let's say if you have cancer, you know, okay, there's 3 months, 6 months, they decline, and then that's kind of expected. So that's where we come in as well, right? Maybe the last couple of months. But then the elderly is quite different, right? The elderly with, let's say, strokes or Parkinson's or dementia, they hang on, right? They decline very slowly. They get infections and then they may recover, and then they get another one, recover. So you never quite know when will be the last, right? But for these patients, generally, once you start to see them decline, we think maybe a year, that kind of thing. There are certain signs that we can use to gauge, right, and guess that maybe time is short. But short means a year, right? Different from when we talk about cancers and all that. Short means months, right? So quite different. So this is kind of the time frames that we have. So very recently, I also had one case. This one is, I think, about 90 or so, dementia patient. So home care, I've been seeing her for about a year, and then she started to decline, eating less and less for maybe a couple of weeks. So it's quite interesting. She's a smoker. So the first sign of trouble is she don't want to smoke already. So don't want to smoke, right? Then something is not right. Then she became weaker. Then after that, became quite big. And it's quite clear that she's deteriorating. And so for such patients who are very elderly, there isn't a benefit to pushing them to hospital again and again and again also. Because when you send such patients to hospital, there's actually quite a bit of suffering involved. Number one, they get plucked out of their home, right? The family can't visit them so often. Number two, at home, the helper can look after this patient. When you go to the hospital, it's one nurse to many patients, right? And the nurse is very busy, right? And of course, the most important thing we could say is that the treatment may not be useful also, right? Because the body is already weak, 90 years old, organs failing. You pump in antibiotics, may not benefit.
To be honest, most people, I've met so many people, they really prefer to die in the comfort of their home, to die in a room that's surrounded by their loved ones. So sometimes I ask them, at the end of the day, like you said, if you send them to the hospital, do they really get the comfort of knowing that they are at home and that they will be passing where they are comfortable and most familiar? And I think a lot of family would like that. But I also have people who said, oh, but maybe we need to go to a hospice. Because hospice, you have care, you have that comfort. But I guess when you're doing home care in palliative, what you're trying to do is manage that pain at the comfort of their home, right?
Absolutely. Surveys have shown it, right? Most patients, 70% or more, really prefer to pass on at home. But that can only be done with the right support, right? So that's why palliative care services are important to support the patients in the home. But it's true that sometimes when patients really can't handle it, then maybe the hospice, inpatient hospice is a more suitable option. There are many cases, of course, where we'll try and manage the patient at home. until a time when they really cannot take it, they're too stressed out, they don't know how to do this or that, then we have to send the patient to an inpatient hospice to be cared for until their last days. Yeah.
And I always remember towards the end of my grandma's life, she asked me to relieve her pain. Right. So why do patients towards the end always feel this, even though we gave her morphine, but she said, well, she was like, oh, 带我走, or 很痛很痛. So how can we, comfort them? Actually, I was at a loss of words, even though I'm in the funeral, or my families are all in the funeral, but we don't know what to say to help comfort her. We were just there to like, okay, let me massage. And the pain is, I don't know, is it nerves? What is it that she's going through?
So I think at the end of life, when the systems are shutting down, there can be many kinds of abnormalities going on. The electrolytes can be upset, right? There can be high calcium, whatever. Those things can cause pain, right? There can be muscle breakdown or whatever, and those kinds of things can be painful as well. Circulation may be poor. So if let's say your hands, they don't get the blood going through, that can be painful as well, right? So, but that's the whole idea behind palliative care, right? It's the physician's job to figure out what is the source of the pain and how can I relieve that pain. And there are so many ways to deliver pain medications. We have morphine and so on, and not just orally. So because at the end of life, sometimes patients can't eat. So that can be given as a patch, injections and whatnot. But that's really the physical side. Okay, I mean, when we talk about pain, we also talk about it as total pain. Pain is pain, physical pain. Then there's also suffering, right? That your grandma may be distressed by it. And so that one actually, your family's presence, that kind of thing, is actually the best you can do. Right? It's very hard to say, I want to make this person happy in the face of pain. Not possible. Right? There's a limit to how much we can do and how much we can help. So we got to be aware of that as well. There can be the reverse as well. So there can be minimal pain but a lot of suffering.
Oh.
So for example, patients, you haven't touched them, right? Then they shout. So that's the mental component much more than the physical pain. So there's anxiety and all that. Right? So you got to see both, right? Both are suffering. So if it's like this, sometimes we have ways to help the patient. Also, there are some drugs to reduce anxiety and make the patient a bit less scared and fearful, right? And of course, family talking to them. In patients who are more well, counseling can help. It's a whole big picture there.
Yeah. Is there any advice that you could give to people who may be taking care of their family members who are towards the end of life?
So, I mean, let the doctors sort out the physical stuff, right? As family members, what you can do is provide them this emotional support, right? And also to support yourself, like I say, right? Same, right? As I said about taking care of my own mental health, so same thing, right? So maybe realizing that there are limits to what you can do, and there's only so much you can do to help this patient, and if you've done it, then that's it, right? You can't expect more of yourself, otherwise then if you get sad or if you get distressed, then you can't also help your parents or something like that.
Yeah, I think to help others first, we need to help ourselves.
Yeah. As part of what I do, I also sign death certs. I've got certified patients have passed away. 15 years ago, when I go into a family to do the certification, very often I get people crying and very sad and in distress. But these days, much less. Do you find that as well?
I resonate with you. Yeah.
Right. So why this is happening, right, is we must congratulate the good work of the hospice services, the palliative care services, preparing the patients for the end of life journey. And I think it is largely because of that, and largely because they've been supported through and they realize what this is all about. Then they don't get into that kind of situation when the time comes. Right, so when you see this, then you realize actually how we take this can be changed one, right, and it can become better, right. So in that sense, slowly I said 15 years, right? That's how long it took to see a change. 10-15 years, right? So slowly, you also realize that actually it's not that bad, right? It's a
Yeah.
fact of life, right?